So first of all, thank you very much for this invitation. And I always look forward to participating in meetings which are associated with cancer, as managing liver tumors has always been my very, big interest. And especially, doing radio embolization, which I felt, I had initiated it right about 15 years ago. So has developed quite a bit of experience in this. And I would share my experience of TARE with all of you. This picture that you are seeing is the contraption which we use to deliver the yttrium-90. This white rod with the green knob there. There is a container behind it over here, the rounded, the yttrium-90 is placed there. And these are the tubings which are then connected to the catheter which goes into the patient. And the catheter is placed selectively into the hepatic artery branch, which is supplying the tumor. So this is the contraption here. Can we go ahead? Just a minute. Yeah. So basically the philosophy behind the transarterial embolization, radioembolization is same as what we used to do for the transarterial chemoembolization. The difference is that now we are using an embolic agent. Basically, these are microspheres made up of either resin or glass spheres. I'm mainly using glass spheres. Now, these spheres are laden with yttrium-90. Yttrium-90 is an isotope which emits beta radiation. And primarily, the beta radiations are very powerful radiations, but they develop very short distance. So they are ideally suited for our kind of therapy. And what is taken up is that the liver, which receives blood supply from dual source, both portal vein and the hepatic artery. And 75% of the liver receives it from the portal vein. But the tumor receives the vascularity from the hepatic artery. So if you can target the tumor via the hepatic artery, that's an ideal way to treat it. And we deliver these microspheres in these branches, which are going into the vascular bed of the tumor. More the vascular bed, the better is the outcome of the whole procedure. So this is what primarily the approach is. And the tumor has a rich capillary network. And these microspheres would go deep into these capillary network and get deposited. Radiation necrosis. So the bulk of the vascularity, when you inject it, majority will go towards the tumor because there is a preferential flow towards the tumor. Now, in our institution, well, we have surgical, the interventional radiology, the radiotherapy, the oncology team, which is is involved in the management of HCC. The whole management strategy depends purely on the patient condition, the performance status, that is the ECOG score, the biochemical parameters, radiological findings, whether the tumor is localized, number of tumors, the size, and the vascularity is very important to evaluate. And more enhancement we see, it is more encouraging to do these transarterial therapy. We also assess the efficacy and safety of a given procedure and then have a tumor board meeting, and we take a decision, and based on the evidence-based guideline and the literature, we take a decision of what procedure is best suited for a given patient. Now, we've all been, following the BCLC algorithm to plan a therapy. And as you know, most of these therapies are now based on the whether there is extrahepatic mets, yes or no, whether the child PERK classification, whether A, B, or C, vascular invasion is there or not, and whether the number of tumors that are there, whether it's a single tumor or multiple tumors. Based on this classification, latest, the Taiwanese classification or the algorithm is probably, completely formalized very well. And I tend to follow this particular guidelines. And you can see that based on this guideline, whether it is a single tumor at, patient condition or child PERK classification, you can see that the radioembolization can be performed at various levels. And you will see that when the tumor is large, when there is the vascular invasion is there, at every level, you can actually use TARE. Even nowadays, you can see that if there is an extrahepatic metastasis and child pug A or B, you can still do a SIRT management in these patients. So you can see that the indications are widened. Now, this would be in short the indication of SIRT in a given patient. Well, there are variable size of the tumor because we do not really worry about the size of the tumor. The location of the tumor is again not our worry. In an early or an intermediate or an advanced stage HCC, we can use this therapy. In an early stage, it is with curative intent where you can do radiation segmentotomy. That means in that segment, we give high dose of radiation. We destroy the tumor as well as the adjacent liver segment with a high dose of radiation. We can do radiation lobectomy in some patients. In an intermediate state, it is very important that you go selectively and give that particular lobar an infusion of this drug and try and destroy the tumor as far as possible. In a locally advanced tumor with portal vein thrombosis, again, you can do internal radiation in these patients by doing a SIRT procedure or a TARE procedure in this. Now, let us look at what are the type of population of a patient where you can do this procedure. When you're looking at a curative setting for HCC, you can do this therapy where you can add it up with ablation or you can bridge it for a resection or a liver transplant also. So you can use a TARE procedure for either of these procedures. When you want to plan a curative therapy, as I said, a radiation segmentectomy or a unilobar radiation lobectomy, I will show you a case of that. The patient performance status has to be very good. The liver function or a child pug should be A or B, and it should be non-infiltrative variety. You can do radiation segmentectomy and lobectomy in these patients. When it is a palliative setting, when the BCLC-B patient who are refractory or intolerant to TACE, SIRT or a TARE is a good procedure. BCLC-B or C patient with a large tumor, multifocal disease, ECOG score should be good, and liver function should be well maintained. There is associated comorbidity is not a contraindicated indication in this patient, and even elderly patient, you can do this procedure. In a BCLC-C patient with a branch or a partial portal vein thrombus, which is again a tumor thrombus, you can do this procedure conveniently as a palliative. This is not a curative, this is palliative. Now, what does the procedure look like? Well, it is a two-stage procedure. In the first stage, we actually do the planning, wherein we will first do the angiogram and demonstrate the hepatic artery branches which are supplying the tumor, look at the vascularity, whether it is very well localized. And this is a good tumor where you can do radioembolization in this patient. I can go into this artery here and inject the dose, and that will completely do a segmentectomy in this area, and we should get a good result. During the injection, we also do what is known as a lung shunting. There are these micro communication between the hepatic artery branches and to the lung, especially in cirrhotic patients. And we want to see how much of the dose which we inject in the liver tumor will go into the lung. And if there is anything more than 20% of the shunting going up into the lung, we do not do this procedure. It is actually contraindicated, or you have to do some additional therapies to prevent this lung shunting from taking place. Now, as you can see in this patient, we have injected technetium-99 into the feeding artery. Here is the infusion artery that we have selected. I've injected there, and you can see focal concentration of the technetium-99 within the liver tumor mass. And if you see the lung, it is just 6.28% going up there. So this is a good suitable tumor to undergo a radioembolization. Once this is done, if there are any adjacent branches, like in this case, I will be keeping my catheter high up there. But if I was to keep my catheter here, this is a cystic artery here, or reflux into the gastroduodenal artery, I would embolize them and then do it. Now with a microcatheter, I don't need to do that, and I can just embolize or do injection right from this level. So infusion deep down is very beneficial in these patients. Once the first stage is done, we take up the patient CT scan and do what is known as a volumetry. We identify the size of the tumor and the area of the liver which we will be infusing. So infusion liver lobe as well as the size of the tumor is calculated. We calculate the lung shunting, and based on that data, we decide the dose that has to be given to this patient and the order is placed. These medications come from Canada or from Australia, and they take anything 7 to 10 days to come. Now, this is a good example that I want to show you is a patient who had an extended thrombus going into the middle hepatic vein as well as into the right portal vein. This was also extending into the IVC, and this CT scan will tell you that. Look at this CT, hypervascular tumor. You can see going into the middle hepatic vein. This is the IVC and it is extending into the IVC. Here you can see that it is going into the portal vein, and this is the thrombus into the portal vein, and this is into the hepatic vein going into the IVC. So this is definitely very advanced stage disease, but the patient's general condition, his ECOG scored, and he was child pug A, and therefore we went ahead and did the procedure. You can see that when I'm making an injection into the tumor area, let me just get my arrow. Yeah, here is my tumor area, and here you can see going into the hepatic vein and IVC. These segments are going down into the portal vein territory. This one here. And this is the left lobe injection. You can see left lobe size is decent enough. So we went selectively into this area and injected a very high dose of yttrium-90, going up to 180 gray. Normally we were working on 80 to 100 gray, but now we are doing higher and higher. The higher the dose and super selective, and you can do a segmentectomy in this and you can see the result. In this patient, you can see the whole of the right lobe has completely gone. The left lobe has hypertrophied here. 1 minute, where is my cursor? Yeah. So you can see the left lobe is enlarged. The right lobe is completely fibrosed and the whole tumor is gone. This patient is now following up for over 5 years now. And during the follow-up, we found that there was another tumor which came up, small little one in the residual left lobe, and we went super selectively into that, and we have done a chemoembolization. So as I said, this super selective injection and chemoembolization of a localized tumor has helped quite a bit. So both these therapies are good as far as overall survival is maintained or managed. So this tumor was very well managed with both radioembolization for the large tumor and chemoembolization for a small tumor. So in my practice, what we do is we select these patients. We use what is known as Dyna CT during the angiography to plan the dosage, which is we put a catheter into the feeding artery and then take a CT scan during contrast injection. And that tells you exact segment or the size of the tumor or the infusion lobe, and that helps us to plan the dosage. We do super selective catheterization to minimize the radiation going to the normal tissue. So you should preserve as much of normal tissue as present. And that also helps me to give very high dose, which is now has a curative outcome. And I will show you some literature or a data on that. Now look at the safety profile of this particular therapy. If you look at the adverse events, it is as low as 1.5 to 1.9%. And often it is fatigue, abdominal pain, and nausea, which are, symptomatic.
Hello, Dr.
You
Vimal.
can get it for maybe 10
Dr.
days
Vimal,
to
can you
2
please
weeks.
conclude?
Yeah, can you hear me?
Sir, can you please conclude? We are running out of time, sir.
Hello?
Hello, sir. Can you please conclude? We are running out of time, sir.
Okay, quickly I'll finish it. Gastric ulceration also is very low. Now, what is the response rate? Here you can see that 52% of the patient had 100% necrosis of the viable tissue, and 48% of the patient had 50 to 59%, which is a very good result. If you look at these patients with PVT, the overall survival, you can see that if it was a child pug A, 13.3 months, and if you are giving a high dosage of more than 205 grays, it is 15.7 months. What are the data in favor of TRE? Early stage, it's a good bridging for between TRE and TACE. Again, TRE is a better survival also nowadays, and even the acceptance is much better. Hospitalization with TRE is much reduced, and you can actually downsize the tumor, cause a hypertrophy of the normal lobe, as you saw in one of my case, and that can also facilitate surgery, and the safety profile is much better than TACE. This is a data that is there. As you can see that the survival benefit, more or less, both of them are same. But nowadays with high dose therapy, the TARE survival is much better. So when you look at TACE versus TARE, again, as I said, the quality of life and toxicity profile is much better with TARE compared to TACE. And you require maybe just one dose, as against TACE, you may require multiple sessions, and therefore costs will be more or less the same. When you look at a comparison of SBRT versus SIRT, again, you will see that there is no limitation for number of lesions that you have to take care of, and it can be even used for advanced stage disease, and at various settings you can use this particular therapy, and the results of meta-analysis, overall survival is significantly better. And as I said, if you give high doses, this therapy is much better. As you can see that in this variety, they are using 190 to 230 grays to get a good result in these patients. In advanced stage, if you compare it with TARE with sorafenib, the outcomes are much better. And therefore, we are now using in combination, not only with sorafenib, but even other biologics or immunologic drugs in some of these patients. So you can see that at a higher dose, the TARE has much better outcome vis-a-vis just sorafenib. This was a sharp trial which gave us this data. And when not to use, well, if the bilirubin is high, lung shunting is more than 30%, poor perfusion or poor vascularity, ECOG score is not good, and biomedical parameters are not good. These are the patients I would not do TARE and would leave it for the other therapies to be used in these patients. In future, there are various other therapies are coming up: phosphorus 32, holium, rhenium, and radio-labeled lipidol. And nowadays, as I said, the oncology, biological drugs, and immunological drugs, and SBRT are other methods that can be used in various cases. This is a case of neuroendocrine. Last few slides, as you can see, multiple nodules in both lobes of the liver. We did what we call as a sequential therapy. We first targeted the right lobe. As you can see that multiple nodules are there. We did lung shunting here, 9.43 lung shunt, which was quite useful. And we did the whole therapy, giving this therapy. And you can see the follow-up. The right lobe, there are multiple necrotic lesions now. The vascularity is gone. Just about a few days ago, we have done the left lobe. As you can see that there are multiple nodules in the left lobe, and we are hoping there will be more or less same results. So in short, Y90 delivers high ionizing radiation dose to the tumor. Palliative intent and control of tumor with increasing survival times has been approved. May permit RFA resection and transplant in those patients where there could be downstaging. These are well tolerated with very few complications. It is very important that you do a proper selection of these patients, do very well technically, and it obviously requires an MDT approach to identify this as a therapy in these patients. Thank you very much.